thing I want to add about UHealth Jackson Children's Care is their emergency rooms at Jackson North, South, West, and the Holtz Children's Hospital are available 24/7, and they're all staffed with pediatric emergency life specialists. So you can be seen usually within 15 minutes, which is incredible. And I always say, I hope you never need a emergency room, but if you do, just file that away. And there's a 24-hour kids only emergency room at Holtz. So all the doctors there are certified in pediatric advanced life support. So you're going to get the best care needed. So that's just a little word for everyone who's listening. Now I am so thrilled and excited to introduce Dr. Latour to you. She is, of course, an OBGYN, dedicated, compassionate, clearly committed to women's health and women's well-being. And she has a passion for providing comprehensive and patient-centered care. So she is an alumna of the Florida State University, where she earned her Bachelor of Science in Biological Sciences, and then she earned her medical degree from the Medical College of Georgia. Discovering a passion for women's health, she completed her residency in OBGYN at Mount Sinai Medical Center in Miami Beach, and her expertise really spans the spectrum. So I was asking our ladies, like, what questions do you have, like, related to birth? So we've got like preeclampsia questions and everything from breathing techniques to what do I pack in my hospital bag. But the great thing is Dr. Latour's expertise spans the spectrum. So she has a passion for high risk OB, but also abnormal uterine bleeding, fibroid care, menopausal care, adolescent gynecology, contraception, infertility, minimally invasive surgeries, as well as polycystic ovarian syndrome. So she's coming with a wealth of information and expertise to share with us. And she is known, which I see and can understand this now, she is known for her empathetic and patient-focused approach. You couldn't be more patient-focused than you have been today. So thank you for also joining us, because I think after delivering a baby, I think I'd want to go just take a minute, but you've come and you're joining us. So thank you for that. And we're just so thankful that you care about ensuring that women receive that personalized and attentive care throughout their journey. And this is part of their journey. So a lot of the ladies that are listening today, but just thank you so much, Dr. Latour, for joining us. Oh, you're muted. Can you unmute yourself? Yeah, there we go.
Okay, so thank you so much for that introduction. I really appreciate it. I absolutely love my job. If you're going to do anything that wakes you up at 3 o'clock in the morning, then you need to absolutely love it. And so this
Better
is what
love it.
And like delivering a baby, you'll never find like, it's the best thing in the world. It's the absolute best. I really being a part of like my patients and their journey.
That is so awesome. Well, I've never delivered a baby, but I've been on the other end of it, delivering a baby. And I gotta say, you guys, the labor and delivery nurses and the doctors, it's such a special calling, because you get to be part of just a new life coming into the world. It's so amazing. All right, we're gonna get started. Again, ladies that are listening, use that Q&A feature if you have a specific question. But we've got ladies here, everyone from looks like 18 weeks to 36, 37 weeks, having babies soon. So lots of good questions, first-time moms, second-time moms. All right, let's begin with just talking in general about labor and delivery. What are the signs and stages of labor, and when should we go to the hospital?
So definitely have a conversation with your doctor. If you're a high-risk patient, they might have different expectations for you to go to the hospital. But generally, we should go to the hospital if we're having contractions that happen every 5 minutes for at least an hour. We say at least an hour because you can have like a string of contractions for 30 minutes or 45 minutes, but it stops, it goes away. And real labor doesn't go away. So if you have contractions every 5 minutes for at least an hour, that's definitely a reason to go into labor and delivery just to be evaluated. Other reasons, if you don't feel your baby moving, that's an immediate, you go to the hospital. If you're bleeding like a period, it could be a sign that you're in labor, your cervix is changing, or it could be a sign that there's something wrong with the baby, and that's an indication to go in as well. And I would also go in if you break your water. It could be like the movies where it's like water everywhere, you wake up in a puddle of water, or it can just be did I break my water? Like, what is that? Like, it's like a little leaking sensation. For that one, I would really just be like, empty your bladder, make sure you didn't pee on yourself. And then maybe put a pad down. If that pad is wet in an hour, you probably broke your water and we should come in and be evaluated.
Okay. Oh, that's good. That's a good tip. I'll say with my first baby, I thought like, oh, did my water just break? And then I'm like, it didn't. Because then when I got to the hospital and it did, I'm like, oh, okay. I feel the difference now. But that's a good tip with trying them with the pad. Okay, so you talked a little bit about false labor. Like, what is that, and how can you differentiate from true labor? Is that technically Braxton Hicks, like when you feel it, but it doesn't last for an hour, or kind of how do you differentiate?
So Braxton Hicks generally has, you feel the belly tightening, but it's not usually painful. So those are like the practice contractions. You
Okay.
can have false labor where the belly is tight. So you'll
Okay.
feel, okay, I feel the belly getting tight, and there's like a cramping sensation with that.
Okay.
Um, that can be painful as well. So it's like, it's really hard to know if false labor, like what is labor? Labor is painful contraction with change in cervix. So we expect your cervix to start dilating if you're really in labor. Unfortunately, 75% of people who have preterm contractions, or maybe fortunately, don't actually go into labor. So only 25% of people who start contracting at 34, 33 weeks
Okay.
actually really go into labor. Some people just have contractions. Um, and so the only way to really know is to go into the hospital just to be evaluated. So they might check you when you initially present, and
Okay.
then they'll give you some time just to see what's happening, and they'll check you again. If the contractions go away, they're not real, because real contractions don't go away.
Yeah.
And real contractions are very rhythmic. They like to dance. So they stay on beat. If they're coming every 5 minutes, they come every 5 minutes. If your contractions are, oh, this one came in 10 minutes and I had another one in 15, and then I had one like every 2 minutes for a little bit and then it changes again, it's not real contraction. It's
Yeah.
not.
Okay. Okay. That's good. They like to dance. See,
They
you're
like
giving
to
us like helpful things to remember. I'm pregnant with my fifth, and I still feel like I have 1,000 questions of like, what's going on with my body? Like, I don't know.
Mhm.
So it's something you're always just learning, you know?
Yeah.
Okay. Talk to us about do's and don'ts leading up to our due date.
Do have a plan. Know what hospital you're delivering at. Know the name of your doctor. Because there are some people who are delivered by different providers than who took care of them. So make
Correct.
sure you know who your OB team is.
Mhm.
Um, make sure you have like your birth plan, like had that conversation with your doctor, but not like have it written down. If you can, tour the facility in advance. Make sure you have your pediatrician selected. Um, all these things can happen later, but it's just nice to have everything ready to go. I always say we will provide everything to you in the hospital, but we don't have chapstick. Bring your chapstick. Bring your music. Bring your aromatherapy scented water diffuser and things that would make you comfortable, because especially we don't know how long your labor is going to be.
Yeah.
You may be in labor for a couple hours, you may be in labor for 3 or 4 days.
Wow.
So depending on that situation, you want to bring things that kind of make you comfortable, but not things that like, we don't need rugs and curtains, but just little
Yeah.
items that you can, that are portable, that you can carry, that will just make you more comfortable in the situation. Don't I think it's more of a do thing. Like the don'ts is more like, just make sure that you're respectful and kind. Like
Yeah.
labor is it's a very interesting course. We don't know what's going to happen. Things change at a moment's notice. We can be looking like we're having a vaginal delivery, and then we can have a cesarean.
Yeah.
Don't come in thinking that like the system is against you and that people are against you. We're
Right.
all here to like help you have um a health and safety like delivery. That is the goal for you
Goal
and the
is
child.
a healthy baby. Yeah. Healthy mom.
So I mean, just come in with like an open mind, and then also just make sure that you understand the process of what's going on. Because sometimes we tell you and then you forget, but it's okay. Oh, you're giving me Pitocin. Can you remind me what that medicine is again?
Yeah.
And like, what are we using it for? Oh, okay, great. Okay, that makes sense. Oh, you want to break my water? Um, do we like, why are we doing this? Okay, are there any risks to doing this? Like, what are the situations? And you can have that conversation. This is a a transfer. This is a care. Like, we don't like, we're not those random countries that just do things to you without your permission and your knowledge and your belief. We want you to be a part of your care, and we want you
Yes.
to understand what's going on.
That's
And
great.
so
I
when
love
things are recommended or things are started or medicine, definitely ask and be like, oh, hey, oh, I know we talked about this before, but would you mind, like, let's just go over
Yeah.
this again. And I
Love
think
it.
that's really great.
I love it. Advocating and like speaking up for yourself and
Mhm.
to understand. And I think it goes back to even the first thing you said, like, know your doctors, like
Yeah.
you get the choice and who you're like walking this journey with. So that's awesome. And Jennifer's saying in the comments too that she recommends taking a tour of the maternity rooms at Jackson Hospital because she said for a first time mom, it helps give you a peace of mind. And I agree. I did the tour. before I had my first, and it was like just one level of like, I know what to expect about something, you know,
You know
like,
where the room is, like, you know
yeah,
how to get into the hospital. Like, if you go into labor in the middle of the night, you might not be going through the main entrance. So now you know, oh, this is the entrance that I will go into. So when you have a little bit of knowledge, it just makes the whole situation a little bit,
that's
oh,
right.
I know how to do this. You feel more confident.
I knew this. Yeah, that's right. Awesome. All right. What about how long is like the average labor? And then what factors can like affect the duration of your labor? Are there certain things you can do or don't to
Yeah.
affect that?
I so for depending on if you're a first time mom or this is your second time or more being a mom, and then also if you're an induction versus a labor. So when you come in labor, your body has already started to doing the work. So your cervix has already been like softened, like the baby's head is already been putting pressure on the cervix is a little bit lower. We're starting with something. You're a little open, you're softer, the baby's down. So it can be anywhere from 12 to 24 hours for like a mom, like, you know, who's already had a child before, and anywhere from like 12 to 36 hours for a mom. This is our first time mom.
Yeah.
For um, patients who are being induced, I would add another 12 to 36 hours to that. So a first time mom being induced, she can have a baby within 24 to 72 hours. And I give it
Wow.
because your body is doing a lot of things on its own. So when you're out in the real world and your cervix is softening and the baby's coming down lower, all of that is helping. So when you come in, you're there. If you come in and you're very closed, the cervix is very long, you need time for our medicines or our procedures to kind of help on softening the cervix and, you know, shortening the cervix and opening the cervix. So it takes weeks in the real world, but it'll be another little 36 hours. Just give us a
Yeah.
little 36, 12 to 36 hours just for that. Just so we can do what happens in weeks, okay?
Wow. That's amazing. That's
Yeah.
amazing. Yeah, I didn't realize I'm an induced one. All mine were
Yeah.
induced. And I was like 41 in 5 days with the first one. And so we started like the cytotech, you know, to help
Yeah.
me. And then it was like it happened really fast. So I didn't know that it could even be up to 72 hours. Like, wow, okay.
Yeah.
I'm learning things. You just never know, which
Hmm.
everybody's different too. Every
Yeah.
body literally is different. Okay, here's a question from our audience. Any advice on how to deal with just the nerves of like a first time delivery? Like it's like you don't know what you don't know, and that can be nerve-wracking, you know?
Interestingly enough, even when I had my first baby as an OBGYN in my hospital that I worked at, it was still nervous because you're like, what is this going to feel like? You know, you're
Yeah.
coaching patients through this all the time. It's a little nervous, but it should just be, I'm not going to say like fun, like, okay, we're throwing balloons, but it should be a fun experience. It's a new experience. And I would say even subsequent pregnancies are different. Every pregnancy is different, every delivery is different. I would just say like have things around you that make you comfortable, have a good relationship with your OB and your OB provider. If you know them and they know you, they know how to kind of like help you move you along. Your labor nurses, all of the Jackson hospitals have the most amazing labor
Amazing.
nurses, and you are going to be like, wow, my nurse is really going to bat for me, helping me. They're going to help you do things like move you and position you in different ways. They're going to give you guidance on like, hey, if you want an epidural, maybe this is the time to have an epidural, or maybe we can do this or that. They're really going to be helpful in that. And so just like really be open to the process. Definitely take a tour, know your provider, kind of know the situation. So when you're here and in labor, we can get things done.
That's great. Oh, I love it. Great tips. Okay, here's a couple questions related to that, just labor in general. But is there anything that you can do to like speed up the delivery? Like, are there exercises? You know, one mom says, I've seen exercise. A lot of moms like sit on a bouncy ball or like, is that accurate? Is that really
I love
helpful?
a bouncy ball. I love a birthing ball. I really do recommend my patients to, again, if we're exercising throughout the pregnancy, that has been shown to reduce the need for cesarean section, and also to like help shorten the labor process because you're more mobile, you're moving around, you're helping the baby like go down, go down. The exit is through the vagina. Okay.
Yeah. Yep.
The other thing is, I love a birthing ball. I recommend that all patients start sitting on a birthing ball at 37 weeks. If you sit on your couch to watch TV, put the birthing ball right in front of your couch, sit on it so that way you don't fall
Yeah.
and keep yourself stabilized. But while you're sitting and talking to your family and friends and just watching TV or eating popcorn
Yeah.
or something, that's a perfect opportunity to like really help get into that deep squat position in a comfortable way. There's no limit to the amount of time. I do know that there's a lot of supplements and things that are out there. None of these things have been proven to work. Some patients are like, oh yes, I totally went into labor because I took this supplement.
Yeah.
And then you can go into labor really quickly if you don't take that supplement.
Yeah.
We know that first time moms typically go past their due date.
Yeah.
So it's not uncommon for it to be like 40 weeks and a first time mom is still not in labor or showing any signs of labor.
Yeah.
Moms that have already had at least sometimes a little bit earlier, but still. So can you speed it up? No, but I think that there are some things like diet and exercise, birthing balls, stretching. Those are things that kind of like really help at least promote or like let the body know, hey, we're trying to do this thing. The exit is down.
Yeah. Okay. Question on the birthing ball. Well, you said it started at 37 weeks. Just sit on it and just get you. Is that just helping like the muscles of your body know that? I don't
So
know
it's
what.
you kind of put yourself in a deep stretch position and that next squatting position. So we're opening up the pelvis and allowing the baby to be like, let's drop down. So sometimes be examined by your doctor and you'd be like, oh, the baby's head is out of the pelvis. So that means the baby's head is not actually inside the pelvis, it's kind of floating above. That's not a problem. We want the head to be floating above. But when it's time for labor,
we want that head down.
and
So when we say head down, that literally means it's in the pelvis at that point. So like, we're like, it's getting close to go time. Awesome. Awesome. Okay. One more question about labor, and we've got lots of categories here. So I'm seeing the questions coming in. We're going to get to all of them. Okay. How is labor and delivery different for women having more than one baby? So like, I don't know if there's anyone listening or is anyone pregnant with multiples? Like, how is it different for those with multiples?
So, multiples, that's a really fun one. So depending on positions of babies, okay? So certain types of twins are candidates for vaginal deliveries. So if you have, they call them di-di. So there's two placentas, there's two amniotic sacs, candidate for a vaginal delivery. If you have monodi, where we still have two different sacs for the baby and one placenta, you can be a candidate for a vaginal delivery. If there is one placenta and one sac, both babies are in the same sac, you are not a candidate for a vaginal delivery. The other thing is like the position of the baby. So if there's two babies, fetus A and fetus B, preferably for vaginal delivery, we would have both babies head down.
Okay.
I would be speaking with your OB provider about their experience doing a breech extraction. Because if baby A is head down and baby B is breech, if your OB provider feels confident and you want one who's like, hey, I feel confident doing a breech extraction, you might be a candidate for a vaginal delivery.
Wow.
If your OB provider is like, hey, I don't have the backup support for this, I don't feel confident, then we should be planning a C-section. If baby A is not head down, then that's a wrap. Baby, like we cannot have a breech baby come first. That's inappropriate.
Okay. That's not gonna, wow. So many things that go into it. I've never.
So like you have to think about it like that. And then also knowing that twins are more likely to be premature or have early deliveries, sometimes just because of the complications that can come with twin pregnancies. So that's another thing where that's a higher risk pregnancy, and having more conversations with your doctor. And at that point too, your MFM, your maternal fetal medicine doctor, is probably going to be involved too in helping craft not only the delivery plan, but the delivery timing.
Yeah, that's great. Thank you. All right. Eating and drinking during labor. What are the rules?
So I think it depends on your hospital. Each hospital has a different set of policies. The reason why I know a lot of hospitals want you to do either NPO or clear liquids is because if there's a chance that you can have a C-section, until that baby is physically 100% out with the placenta, there's always a chance that we might go back to the OR. And if we have, because if the placenta doesn't come out, that's an indication to go to the OR.
Wow. I've never thought about that, but you could actually have to like surgically remove the placenta even if you had a vaginal delivery.
So the reason why people are concerned about that is if they have to do general anesthesia where they have to put a tube in your mouth and there's food sitting there, sometimes you can aspirate the food and that can cause aspiration pneumonia.
Okay, yeah.
And we just had a baby. We don't want to be in the ICU. So that is one of the reasons why that rule is there. I would have, again, this is what the tour is useful for, and having a conversation with your OB provider and be like, hey, what are the limits? Oh, okay. Some people might say once an epidural is in place, we can't eat. If we're having an induction, a long day induction, for me, I'm like a clear liquids girl. I'm like, please have your Gatorade, and I just want to keep you hydrated as much as possible, and just have like, we're not in jail. So like Jello and
Imagine
like
those
soft
ice cubes and all that. Yeah.
yeah, your liquids after 2 hours, we're fine. And then if we're like, hey, we're getting more closer, we're advancing in our dilation, we're like in active labor, 6, 7, or 8 centimeters, that might be an indication to be, hey, let's stop on like the food, let's go to clears, or let's just stop clears altogether. Again, that's a good conversation for like on the tour, because the hospital may have a policy alone, and then also talking to your OB provider to see what their like stance on that is.
Awesome. Okay, that's helpful. All right, we've got a question from our audience about thoughts on epidural. There's so many misconceptions online, like, can it affect me long term? Like, what should we think when it comes to that? And then we'll talk in general about pain management and which options are available. So.
I won't lie, I'm team epidural. My parents came from Haiti, and I'm like, there's so many countries that just don't have these resources available. When you have them, it can be really nice. An epidural that's placed right and like helps with the pain management a lot can be a really satisfying situation for the patient.
Yeah.
I think from an OB standpoint, there's always benefit of having an epidural, because if there's an obstetrical emergency, postpartum hemorrhage, shoulder dystocia, a need for like a vacuum or anything else like that, then you can really do more maneuvers and get more things done if the patient is sort of numb from the waist down.
Right.
It also does help if there's like a need to go back for emergency surgery. The epidural's already in place. We don't have to consider general anesthesia.
Yeah.
Now, it is the patient's preference. I have tons of patients who deliver without an epidural. They do it all the time. I don't think epidurals slow down labor, because to be very honest, patients who don't have an epidural and they start pushing earlier, which can be a little dangerous, but it's just a situation of what happens. It does help with, if you don't have an epidural, you definitely know when you're having a contraction, you definitely know how to push, and that period of learning how to push is a little bit shorter. But your OB providers, we're all really good coaches on like how to push. We can see your contractions on the tachometer. We can palpate them on your abdomen. We'll know when to let you push, and we will just help guide you on like, hey, when you're pushing the next time, let's try this position. Let's do this. Let's hold our hands here.
Yeah. No, that's great. Oh man. Okay. I want to talk about pain management, but on that, I want to deviate a little bit, because the delivery team is so important. Like just having those people coaching you, and especially when you're like, I don't know what it's supposed to feel like. I don't know what I'm doing. Talk to us about who would be present during the delivery, and can you request a specific birthing team or a midwife, doula? How does that work?
So your OB provider, so depending on the type of OB practice that you may be a part of, you might have a doctor who this is the one doctor for the practice, so they attend all of the deliveries. You might be a part of a group practice. It might be whoever's on call. Some practices will be like, these are my patients, so I attend all those patients. So that might be a situation. I think most people, you might know the different doctors, like, hey, I've seen all these different doctors in the practice, and therefore I will deliver with one of them. That's usually the situation. For requesting, that would be done with like your OB provider, and like letting them know, hey, can I request you for the delivery? What is the process to doing that? That might mean, hey, we're planning for an induction as opposed to going to labor, to like accommodate for schedules.
That's right.
You're going to have your labor and delivery nurse is always going to be with you. You're going to have, you might have like a surgical tech or PCA, somebody who comes in and help bring in instruments and supplies and equipment into the room. The baby has its own set of team that comes with them as well. So the baby has a baby nurse, depending on the risk level for the baby. So if we're like low risk, no interventions, it might just be a baby nurse to kind of help transition the baby to like the new outside world. And then if the baby, maybe there's like a meconium, or there's like, we know from before like delivery that the baby was going to have some like problems that needed immediate attention. You would have like the neonatologist at bedside. You may have like a respiratory therapist, and these are people who are dedicated to the baby. So
Amazing.
you have a doctor and nurse dedicated to the baby. You have a doctor and nurse dedicated to the birthing parent.
That's incredible. Just the amount of resources, I remember
Mhm.
that's one of the things, there's kind of like a funny meme going around, or reel that's like, the 1,500 people that come in like after
And
you've had a
trust
baby
me,
and you're like,
these greens, if
yeah,
you see a whole bunch of people with green things running around, there might be an emergency. And
yeah,
let's just like, okay, hey, if there's an emergency, a lot of people, our labor floors at Jackson are super amazing. They know how to handle emergencies. And in labor and delivery, it happens like in a blink of a second. So
yeah.
people just run in and they just know how to handle things.
That is so awesome. I'll never forget. And everybody has their own journey. With my number 3, we labored and he was crooked and turned, and he turned out to be almost 11 pounds. So we ended up having to quickly do a C-section. And it was like all of a sudden it was, us and our one nurse. And then all of a sudden it was like 10 people in the room. And I thought, okay, but it's just the comfort of everything was taken care of and we were just in
Yeah.
great hands. So it's just awesome to know the amazing resources available. So all right, we talked about birth plan. The delivery team who's present during delivery, all of that's great. Let's talk a little bit more about pain management. So talk to us about what other pain relief options are available during labor and how they work. And then also, are there any non-pharmacological pain management techniques that you recommend?
So with the non-pharmacological, so like positioning, walking, using the birthing ball, breathing. And I really do think that at the end of the day, as painful as pain can be, it is literally a mind over matter situation. Like pain is weakness leaving the body. I'm not having contractions. These are just like moments. And like if you go in knowing that like it's gonna be super painful, you are gonna feel like everything is super painful. The right mindset.
Yeah, that's right.
I'm approaching contractions. What are the purpose of the contractions? The contractions are there so I can see my baby.
Yeah, that's right.
I can meet my baby. So instead of being in fear of my contractions, I'm embracing my contractions.
Yeah.
So like your mindset and how you approach these things is one thing. Um, so always with the positioning and the movement, you guys get those little fans, the ones that you'll eventually put on the stroller, because you'll just
Oh,
get hot. So the
yeah.
little fans, yeah, just get
Yeah.
one of those, especially
Put
the
on the
ones that
bed,
have the
Yeah.
little, you can just like put it on the bed, like just attach it real quick. Those are
Uh-huh.
very helpful. If it helps when you're like, okay, if I'm meditating, if I have a song, if I have a beat, if I have okay, the contraction's happening, this is the one thing I'm going to do to help with that. So depending on your different locations, epidurals are available. We have something that's called remifentanil, where it's a little IV medication that can help with pain. Your provider can give you morphine, Stadol, fentanyl, like through the IV, and these are things that can help with pain. We generally try to stay away from narcotics because unfortunately in pregnancy, the only thing that helps with pain is Tylenol and narcotics, and like Tylenol is not going to really help with contraction pain.
Yeah. Yeah.
But the narcotics, we do not like to use them like towards delivery.
Okay.
Because we don't want the baby to be sleepy. They do get exposed to the narcotics. It's not a dangerous thing. It will come out of their system. But like within 4 hours, if we think where delivery is going to happen in 4 hours, we generally stop narcotics.
Okay.
Epidural is a good option because the pain management is completely within the mom and it's not affecting the baby.
That's
So
awesome.
that's another indication for that.
Wow. Okay, great. Ladies who are listening, isn't this so encouraging and so helpful? Okay, lots of other questions coming, so I'm gonna keep them coming after you. Okay, someone asked about epidural. Can you try multiple birthing positions, or do you have to stay on your back if you have an epidural?
So I think it depends on like the level of epidural. So sometimes people are like, oh, I have a soft epidural. I think that's more of a question for anesthesia, your anesthesia provider of like, hey, generally, how does this work? Do I have a spinal epidural? Or do you have a straight epidural where the level is being built? Because a spinal is like a spinal, you'll be numb. And then the epidural kind of comes into play afterwards because the spinal only lasts for so long. And then the epidural will go as the level is built. If you get a straight epidural, you're not going to get 100% pain relief right away. It's something that builds over time.
Okay.
So that would be a question for the anesthesia provider, either the anesthesiologist or the CRNA. about, hey, like, what are my options for epidural or spinal? Am I a candidate? Patients who've had like scoliosis or spine surgery, I would recommend talking to your OB provider about you having a consult with anesthesia prior to delivery. We don't want to find out in delivery we can't have an epidural.
Right. Okay. What is when you say asking them, I have 4 epidurals. And so I'm just like, give it to me, give it to me.
Yeah.
But I never knew to ask, like, what's the difference in the spinal versus the epidural? Or
So,
I
and I
just
think
say, like,
most
rip me up.
people, so like the spinal is, so when you're having a C-section, we just give you a spinal. So it's local anesthesia that kind of goes and it just numbs, and it's a stronger dose. The epidural is, it slowly builds a level. So like it's the medicine's going through the catheter. You start off with a little baby dose. And then as the medicine is going through the catheter, the amount of medicine kind of increases.
Okay. That makes
There may be indications for that depending on like, oh, I have like a heart failure issue or such and
sense.
such and this and that. If there's like blood pressure issues, there might be a difference in what kind of medication that they use. But that's a question for like the OB provider, the anesthesia provider. But if you are a person who's like, I don't really want to be in one position, maybe an epidural would be a better option for you because you're not going to be completely numb.
Right.
And they can control the amount of medicine that you get. I know in other countries they have things like walking epidurals, and then some facilities, some OB providers are like, yeah, like I have some where you still have like a lot of movement in your legs. And then there are some like, you know, epidural that you're just like completely numb, and like
Oh, yeah.
you might be able to move a little bit, you feel pressure, but you don't feel like, you don't have like, you can't get up and walk.
Yeah. Yeah.
Um,
Okay.
and then depending on like your level of epidural and your birthing position, I think you can labor in almost any position. I think birthing position, talk to your provider about like what positions they're comfortable with. I think babies can come out in any position, but if there's an emergency like a shoulder dystocia, we are trained to do them like when the patient is on their back. So like, okay, are we losing, how many like seconds matter when we're talking about baby and like potential neurological compromise?
Yeah.
So is that something where like, hey, we can labor in any position, but when it's time to deliver, we're going to be on our back. If
Yeah.
we're not delivering on our back and we're delivering on all fours or squats, or are you able to do those shoulder dystocia maneuvers in reverse? And so
Right.
if something, so that's a good question for your OB provider, and be like, hey, like I think I want to deliver like this, I think I want to deliver like that. And then they'll just be very open about like, hey, I'm very confident with this delivery. And like when we're like actually doing deliveries, I would prefer this position so we can do these maneuvers if there's an emergency.
Yeah. Okay, let's talk about just because I don't know. I'm a fifth time mom, but as a first time mom, I mean, even still now, it's like hearing all that. I'm like, oh wow, there are so many things that are like variables or that could go wrong or could go different than you plan, you know? So I don't want to scare the mamas, but also let's talk about complications and interventions because things can happen. So you're talking about like the shoulder dysplasia, is that what you called it? Like, okay, so what are like common complications during labor and how are they managed? But then also like the shoulder thing, like how, I don't know, statistic, but like how that's not like 80% of births have this, you know, like that's very rare kind of thing. So
Yeah.
talk to us about that.
So a shoulder dystocia is when the baby's head comes out, but the shoulders are unable to come out. So they're like stuck under the pubic symphysis, so that pubic bone that you can feel when you're pressing down your pelvis. And so that is an emergency because the head is out, but the shoulder's not out. And so we have to do maneuvers to get that shoulder out. It is considered to be one of our obstetrical emergencies. Sometimes you can kind of see like, oh, this is a potential to happen. And that's one of the reasons why your OB provider might be like, hey, we think that the baby is too big to come out of the pelvis. We're concerned that there might be something called a shoulder dystocia. We might recommend to have a C-section as opposed to trying to go through just to avoid the potential emergency.
Right, right. Yeah.
There's postpartum hemorrhage, and postpartum hemorrhage is when you're bleeding after delivery. I think the benefit of being here in the United States is that we handle postpartum hemorrhage really well. It's the #1 cause of maternal mortality in the world, but not in the United States because we actively manage labor. We give you a thing called Pitocin to help your uterus snap back. We massage your uterus. We deliver the placenta in a timely manner. All of those things help with reducing bleeding. But if there's bleeding and bleeding and bleeding that happens, there's medicines that we can use, there's balloons we can place, there's procedures that we can do in the OR. Depending on what causes the bleeding, there's options for that.
Yeah, that's awesome. Wow, so many things available to protect
Mhm.
us. Okay, great. So we talked about under what circumstances might interventions like induction or cesarean be necessary, like again, consulting with your OB team and
Mhm.
make sure. And yeah, like I went in not hoping for a C-section, but
Yeah.
we had cord issues, we had heart rate issues all of a
Mhm.
sudden. And it was
And I
like my doctor, like you said, just worked with these. We tried everything and he's like, we need to go C-section. I'm like, let's do it. And then when the baby came out and the accord, and it was like, okay, you trust your
yeah.
doctors. They know what they're doing. And then healthy,
Mhm.
huge baby. So thankful for that.
Yeah.
Yeah, massive babies. Okay, let's talk about episiotomy and perineal. Am I saying that right? Perineal care.
Yeah.
Just because that's new world when you have a
Yeah.
baby. But under what circumstances might an episiotomy be recommended?
So episiotomy, if we think it's a bigger baby, can you hold on for 1 second?
Of
Hold
course,
on.
yeah. And just a reminder, ladies, if you have questions, you can put those in the Q&A and I'll get them in front of Dr. Latour. I'm watching our time. We might go just a few minutes past 1, just since we started a little bit later, but just know I want to respect your time as well as the doctor's time. But you get those questions in and I'll get them in front of her.
Okay. Sorry about that.
No
So
worries.
in episiotomy, if we think that the baby might be a little bit bigger, sometimes it's done to like shorten the labor course, but predominantly it's done for like maneuvers. So like if we think that there's a shoulder dystocia, we might do an episiotomy to give us more space so we can do our maneuvers. Perineal care. So like obviously we put pressure on the perineum so as the baby's head is coming. We put pressure so that the baby can descend. And then try not to like cause a lot of tearing.
Yeah.
First and second degree, you might hear like levels of tear: first, second, third, and fourth. First and second degrees are the most common for all of them. Third degree would be like a little bit of the sphincter muscles. The anal sphincter muscles are involved. And then a fourth degree is at the rectus, like the rectal mucosa. So that's like when somebody's like, oh, I was like, the baby tore me from like completely
Yeah.
through everything. That is that. And
Hmm.
so OBs, your OB provider is trained on how to like repair these things. Sometimes that we might have to bring you to the OR just so we can have like better lighting and visualization so we can repair them properly.
That's great.
But very rarely there's a third and fourth degree happen, but it is something that can happen, especially if there was like a shoulder dystocia or if it's a bigger than expected baby.
Okay. Question, I think sort of related to that, but someone's asking, is there a benefit to forceps versus the vacuum, or are either important to have options?
Um,
And when would that be needed? Like, would that be like maybe stuck kind of deal?
so yeah, just like if we're at a certain station, so like the baby is definitely within the pelvis, and to like kind of help assist the baby descend.
Mm-hmm.
Sometimes if like the baby's head is like shifted, so it's not like directly coming through, but it's like kind of one of these things, you can kind of use a forceps predominantly to kind of maneuver and change. Your OB provider may be like more skilled and more trained on a forceps or more skilled and more trained on a vacuum.
Okay.
There are some like contraindications, like really preterm babies are not really like there's certain age limits that you can have for both of them, but it's depending on like your skill of your OB provider and then like what they choose to do. And then if we start pushing, it kind of helps with that.
Okay.
I not even just to shorten the time of to delivery, but also if the strip is concerning. So we're concerned that hey, the baby might be getting compromised soon, like they're having a lot of D cells or they're a little bit bradycardic. That can be concerning.
Okay. That's helpful. Thank you.
Mhm.
Back to episiotomy. Someone asked, like, would your OB let you know if they are performing that,
Yeah.
or they
Yes.
just do it, or
Immediately. Yeah.
like they would tell
Yeah.
you? Okay.
Yes. Yeah.
They were like, heads up. Okay, great. Let's talk about C-section quickly. And you've talked to some of these already, but what are reasons for a C-section? And then how is the procedure performed? And then talk to us about the recovery, because it is a little bit different.
Hmm. So C-sections might be because like, hey, your baby may have like some type of malformation that doesn't allow them to be delivered vaginally. So that's an indication. Multiples, the baby is breached, the baby's sitting, it's unsafe to do. It can be very concerning to do a breech vaginal delivery, and then we know that we have better outcomes with a cesarean section. If the baby is you're in labor and you're not dilating, and it's been a significant amount of time, and we're not making any change despite being ruptured on pitocin, those things, that's an indication for a C-section. If we've been pushing for at least 4 hours for a first-time mom and the baby is not going anywhere, that's an indication for a C-section. If we tried vacuum and forceps and those failed, that's an indication for a C-section.
Okay. Thank you. All right. And then just recovery process.
So recovery, so you are generally, so if you have an epidural or spinal, that usually covers you for about the first 12, 18 hours. We do give you Tylenol and ibuprofen generally around the clock because we know that that helps the best with pain management. And then if you have some like breakthrough pain, either oxycodone or Percocet, like some form of narcotic that can help you with that. It is a major surgery, but it is the most common surgery in the United States. More people are getting C-sections than appendectomies, cholecystectomies, like gallbladder removed or anything altogether. So it is a pretty common surgery. 20% of pregnancies will probably end in a C-section.
Wow, 20%.
Okay.
And I remember too, no one tell, not no one told me, but like having someone tell me, friends that have been there and nurses, like when you feel like you need to sneeze, like hug that pillow.
I like that pillow,
Like
yeah.
that. I'm like, oh, I was not prepared for that,
Yeah.
Um,
And we don't want you to be on bed rest. We don't want you to not take a shower, get up, walk around. And we like to see you kind of try to do those things at least on day 1 and day 2 after the C-section, because we want to know that you're okay to go home, that your pain is tolerable with the medication. Generally, your OB provider will see you within like 1 or 2 weeks to kind of look at the incision and address the wound. They'll give you like just kind of like education and information on like what are signs to come back.
Yeah.
And things like that.
Awesome. Awesome. All right, let's talk about induction. So in what situations might labor be induced and what methods are used?
So we can induce if there's like a medical indication. So generally, I feel like in this area, it's like you have diabetes or you have hypertension, you have preeclampsia. There might be some issues with the baby. The baby might be small. There might be little fluid around the baby. Those are things that can happen. Twins are more likely to be preterm, so there might be like an indication to like do those deliveries earlier. Methods, we have medicines that's something called Cytotec, which is a little tablet. They can either put it under your mouth, you can swallow it, they can put it in the vagina, and that just helps with the softening of the cervix. We have something called Cervidil. It's a little strip tampon that can go inside the vagina, and it sits there for 12 hours. We can do a balloon induction with something called a Cook balloon. We put the Cook balloon in the vagina and in the vagina through the cervix, and then one balloon is like next to the baby's head and one balloon's in the vagina, and it pressures and opens at the same time. And then we can also just do Pitocin. For our moms who've kind of been there before, if you're like a little open, sometimes you might just say, let's just go ahead and break your water, and that can be your induction method.
Yeah, that's awesome. I'm watching our time. It's 12:55, and so I want to respect your time, of course. You may have to deliver another baby, but do you feel like we can go like 5 or 7 minutes over? I'm working through our questions, but we've got a few more. Are you okay with that?
Yeah, we can.
You have a hard stop at 1. You tell me, because I'm just gonna keep them coming, and then we'll get them out.
Let's do like 102, 103.
Perfect. Okay, we can do that. All right. Are there any potential risks associated with induction?
Not generally. Like the risks are just the same as like going through labor. There's always this similar risk of going through a C-section and stuff. Some people think that if I have an induction, I'm more likely to end up with a C-section. That's not the case. If the induction failed for some reason, then it probably would have failed. You probably would have had the same situation in labor. And that's just like reality. But no, not generally, especially because you're here in the hospital. It's very kind of controlled.
Awesome. Okay, great. Let's talk about VBAC. So vaginal birth after cesarean. What factors influence that? What risks, benefits are associated with attempting a VBAC?
I think family size, how many children do you think you want to have, if you've had a vaginal delivery before, and the reason why you had the initial C-section. And also whether or not your OB provider is like willing to provide or like offer you that service. Okay. So all of those things are in place. Talk to your OB provider and be like, hey, I had a C-section. Do you perform VBACs? Under what circumstances? Some people might be like, oh, that's fine, I can induce the VBAC. Some will say, no, you have to come in labor, the baby has to be a certain size, etc. Why did you have a C-section the first time? I had a C-section because my baby was breech. Okay, well, you never tried labor, so we don't know if you failed it. I had a C-section because I was pushing for 4 hours and the baby never came out. probably not a good candidate for a
Yeah.
VBAC.
Yeah.
So those are the kind of indications and things like that.
Yeah. No, that's helpful. Thank you. Okay, let's talk about alternative methods. So are there any alternative birthing methods that you recommend or maybe you discourage?
I am a strong believer that you should have your baby in the hospital.
Mhm.
I know that some people are like, I want to have a baby at home, I'm medicated with a doula. I think 90% of the time, my job as an OBGYN, like, it's not necessary, but that 10% that we never know. You can
Yeah.
be low risk, have the most low risk, very boring prenatal course.
Yeah.
And when it's time for delivery, the emergency can happen. I think that we should, like, as parents, kind of think about to the hospital, you have to be registered. We have to get your labs. We have to get things. There's going to be a delay in care if you're coming in from home with an attempted delivery as opposed to being in the hospital.
Yeah.
So I think for me, like, definitely we should try to have as many deliveries in the hospital as possible. And we can make I feel like we can make your birthing like situation and the feeling and the environment very much so like your like what you desired from like your home.
Yeah.
But I really do think that we should have babies in hospitals.
Yeah, that's great. Thank you for sharing. And I'm an advocate too. Like you do you, but I'm like, I love the comfort of all the beeping machines and the people in scrubs attending to me.
Yeah.
That makes me feel very good. Okay, we're almost finished. We'll wrap up a few more things. On the note of that, you're saying all the pre-registration, all the things that happen. How soon in a pregnancy should you visit your OB? Just like maybe even like first visit. Like how soon should you develop that relationship?
Definitely within like the first 12 weeks or so.
Yeah.
I think it's just important to like come in, get established, get dating correct.
Yeah.
A lot of things in OB are dependent on like your dating, and the earlier you go in, the earlier we can have that dating. And then there's early testing that can happen, that can help you make decisions on like how you proceed with your pregnancy. So definitely within the first trimester, if you move, like let's say you leave Florida and you go to a different state, try to establish OB care as soon as possible. Bring your records from the place that you were before to your OB provider and just like really be honest. Like, we're not judging you. Hey, you had a history of STDs, you had surgery before, you've had abortions, you've had miscarriages. Let us know everything so we can help you plan for your pregnancy appropriately.
That's right. That's great. Wrapping up, but talking about, and you spoke a little bit to this already, but remind us how equipped the hospital is to handle unexpected complications during labor and delivery.
100% all the time, everything. And it
Yeah.
happens at a drop of the dime on a regular basis. Emergencies happen and we handle it perfectly.
Yes. I love it. Okay. Last couple of things. You have the baby, you're going to appointments all the time, all the time, all the time. Then you have the baby, but you do your follow-up appointment if you have a cesarean and it's like sooner. But after the mom gives birth, when do you go back to the OBGYN to check mom and baby?
So generally within the first 2 weeks, you're going to have your initial postpartum appointment with your OBGYN just to kind of see how things are going, assess for depression, help with breastfeeding, look at pain, look at bleeding, just making sure that we're transitioning well. And then you might have another appointment in like 4 to 6 weeks after that, just to kind of have like a couple looks. So ACOG, which is like the medical college that kind of helps give us guidance for like OBGYNs, is like bigger proponent for like the fourth trimester, so like the 12 weeks postpartum. And so just making sure that we have an early check-in to look at blood pressure, to look at depression, to make sure that moms are doing well, as opposed to, hey, we'll see you in 6 weeks. We don't do that anymore.
Right. Right. That's great. Oh, I love that. Okay. Last final thing. And then I'm going to let you pop off and I'll do kind of the closing remarks, but, let's, I don't know, debunk or whatever, some of the myths, or maybe they really work. I don't know, but I hear things like eat dates, eat pineapple, drink castor oil, like all the things that would help induce labor. I don't know. Tell us, are they wives' tales? Are they maybe, who knows? It's different for
Maybe.
everybody.
I think
Maybe.
if you are not constipated before delivery, that does help.
Yeah, that's
So
good.
like enemas, the castor oil, because it clears you out, dates,
Yeah,
they'll clear you out. That part, but like, do they start labor and help things go along? No, but do whatever makes you happy. Because
that's
sometimes if
right.
you're like, it doesn't hurt. So if it makes you happy to do it, then just do it.
That's right. That's right. Dr. Latour, I'm going to let you slip off because you have been amazing, everyone. I mean,
Thank
if we
you
could
so
just give
much.
you a virtual round of applause, we would. Thank you for delivering that sweet baby boy and jumping on with us. We just appreciate you. And we give you a big wave goodbye and say thank you because I know you need to
Thank
slip
you
on.
so much.
Thank you. Thank you. We just blessings to you. I'm going to show those of you who are still on here, our guests, you can screenshot this template right here. This is some great resources. You can continue your study. I also want to say, okay, mamas, you have the baby, and then you have all the questions about nursing, lactation, feeding baby, sleep, all that. We have webinars on all of those topics. So parentalguidance.org. I'm so used to the old website, parentalguidance.org, and go check out those resources there. Here's other great resources as you plan for your pregnancy. If Miami Mom Collective can do anything to support you in your journey, we're here, as well as UHealth Jackson Children's Care. Of course, please do mark your calendar. We do these every month. So our next one will be Thursday, March 21st at noon. And it is going to be on the topic of understanding cerebral palsy. So cerebral palsy is the most common motor disability in children, and it's caused by abnormal brain development. So it affects a person's ability to control their muscles. So tune in and learn the causes, effective therapies, treatments, as well as resources that are available for CP support. So that will be Thursday, March 21st at noon. So you can make a note of that. But to all you mamas out there who are just expecting little ones, we just rejoice with you in this exciting time, and just do some breathing. It can be nerve-wracking because there's a lot of unknowns, but it's just, Lord willing, can be a beautiful experience for you and your babies. And so we are cheering you on. We're here to be a resource for you. If there's anything we can do, please let us know. So thanks for joining us today, and we hope to see you again on Thursday, March 21st at noon.